The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome back to In the Loop with Nadja Wlasiuk. In this episode, we are diving into a rhythm that affects millions of people worldwide, atrial fibrillation. Atrial fibrillation, or AFib, is the most common heart rhythm problem that we see. In the United States alone, more than 5 million people are living with it, and that number is expected to double or even triple by 2050. It accounts for a huge portion of hospitalizations and long-term medication use, and it can have major impacts, not just on health, but on quality of life. So if you're a patient who's just been diagnosed and feeling overwhelmed, or you're a family member trying to understand what's happening to your loved one, or if you're a nurse practitioner, or healthcare provider who wants a clear evidence-based resource to share with patients, or just to refresh your own knowledge, this episode is for you. I'm going to walk you through what atrial fibrillation is, why it matters, and the different ways it can be treated, from medications to ablation to lifestyle changes. My hope is that if you're a patient, this can be something you come back to after a clinic visit when you need a refresh, because I know it's hard to absorb everything all at once. This podcast is for education and information only. It is not a substitute for your own medical care. Please talk with your healthcare provider about your own individual situation. I am so excited about this episode on atrial fibrillation because it's almost like you're going to be with me in a visit with someone learning about atrial fibrillation for the first time. This is, again, entirely for informational and educational purposes. This is not medical advice. And if you have atrial fibrillation or you know someone who has atrial fibrillation and needs specific medical advice, please seek out the expertise of a healthcare provider that knows you. Okay, that being said, let's talk about atrial fibrillation. First, I want to talk about the normal conduction of the heart. So what is normally going on in your heart, your heart pumps blood. That's the job of the heart, to pump the blood, right? So how it does this is through contraction of the muscle, which is generated by an electrical impulse that comes from the heart's natural pacemaker, normally, which is the sinoatrial node or sinus node, which if you ever hear anyone say, oh, you're in normal sinus rhythm, that's what it means. It doesn't mean your sinuses in your head. It means your sinus node in your heart. So your heart is an organ that is comprised of 4 chambers, 2 on the top called atria and 2 on the bottom called the ventricles. The sinus node lives in the high right atrium, so the top of the right top chamber of the heart. It sends out a signal across the atria that goes down to the AV node, which is in between. The AV node is the atrioventricular node, which is between the atria and the ventricle. Very simple, right? So the signal gets sent across the atrium. The atrium give a good squeeze blood down into the ventricles. As this electrical impulse is at the AV node, the blood's filling up into the ventricles. It kind of has a little pause there. We can get into some really deep weeds about the conduction system, but that is way outside of the scope of this podcast right now. Maybe someday later, I'll get an expert in to tell you about it. But anyway, it stops at the AV node real quick while the ventricles fill up with blood, and then it travels down the bundle of His and through the bundle branches, and then that causes the ventricles to give a good squeeze, and they send blood to the lungs and out to the body. And it's that nice contraction, that lub-dub. So the electricity is helping move the muscle. So the atria give a good squeeze, and then the ventricles give a good squeeze. Well, in atrial fibrillation, the electrical impulse is not coming from the heart's natural pacemaker. It's coming from outside of that. And the hallmark of atrial fibrillation is an irregular rhythm, because it's just kind of like chaos. Instead of getting that nice signal where it's giving a squeeze, it's getting all kinds of signals. So if you think about like fibrillation, it's like quivering instead of giving a nice solid squeeze. So the atria are quivering, and they can go really, really fast, like 300 beats per minute from the atria. That doesn't cause the ventricles to go that fast because you have that node there stopping that, but it will make the ventricles confused sometimes, and sometimes they can go faster than they should, and it's very irregular rhythm. Atrial fibrillation is the most common dysrhythmia of the heart, affecting 1 to 2% of the global population and more than 5 million people in the United States. Numbers are expected to double or triple by 2050 as the population ages. Atrial fibrillation accounts for a substantial portion of healthcare costs secondary to hospitalizations and long-term anticoagulation therapy. Atrial fibrillation is more common in men than in women, but women tend to have more severe symptoms and more complications. The symptoms of atrial fibrillation are palpitations, where it feels like your heart's skipping a beat or racing, or like there's butterflies in your chest, fatigue, shortness of breath. Some patients experience shortness of breath at rest and some with exertion. They normally go for a 2-mile walk every day, and now they're noticing that they're short of breath all of a sudden. You can feel dizzy, you can feel chest tightness, chest discomfort. Some patients are entirely asymptomatic. My uncle has been in atrial fibrillation for probably 20 years. He doesn't even know he's in it. So I have patients who know anytime their heart's out of rhythm, and I have patients who have no idea when they're in AFib or not. Paroxysmal atrial fibrillation is any atrial fibrillation that lasts less than 7 days and is self-limiting, means that patients can convert back to normal rhythm on their own. Persistent atrial fibrillation is atrial fibrillation that it lasts for greater than 7 days or requires an intervention for conversion. Long-standing persistent atrial fibrillation is that lasting more than 12 months. And then permanent atrial fibrillation is when we've decided not to do anything further about rhythm control. So what are the important factors about atrial fibrillation? Why does it matter? Why do we need to treat it? Well, atrial fibrillation alone, without looking at any other factors, increases someone's risk for stroke by 5 times. So why? Well, remember when I was telling you how normally your heart gives a good squeeze on the top chambers and then on the bottom chambers, so blood is just moving how it should. It's getting all squeezed out and it moves around the heart and the body. Well, in atrial fibrillation, when those top 2 chambers are quivering, blood can hang out in there and it doesn't move like it should. And when blood doesn't move properly, it has the opportunity to clot. And when it does, it makes this big old clot and doesn't go anywhere for a while, and it's clotting and clotting. And then you get a good squeeze and it shoots it up to your brain, and then there's a stroke. So definitely that's like the biggest risk with AFib. That's one thing I always tell my patients, is that atrial fibrillation is generally not life-threatening on its own, but it does increase your risk for stroke. So it's very important that you are continuously managed by a cardiologist or an electrophysiologist. Atrial fibrillation increases your risk for heart failure and heart failure hospitalizations by 3 to 5%. There's poor pumping efficiency and structural remodeling, and there is something called tachycardia-mediated cardiomyopathy, which just means tachycardia, which is a rate faster than 100 beats per minute, causing cardiomyopathy, which is a weakened heart. So I always tell my patients it's a $200 phrase. That's just meaning a fast heart makes a weak heart. So if your heart is beating really fast for a long time, it can weaken it. Atrial fibrillation can increase your risk for dementia 2 to 3 times higher than someone who doesn't have atrial fibrillation, and causes some cognitive decline. This is thought to be in part by silent cerebral infarcts, reduced perfusion, microembolism, and chronic inflammation. Atrial fibrillation can also decrease your quality of life. Think about those symptoms like fatigue, reduced exercise tolerance, and cognitive decline. And if you're having palpitations all the time and you're just not feeling yourself, it definitely plays a big part in that. So what are the treatment goals? One of my mentors and physician attendings that I work with right now, he has a couple of practice mantras that I like to think of every time I go in to see patients. And one of those is, we never want to make the cure worse than the disease. And there are only 2 reasons that we practice medicine. 1 is to help someone live longer, and 2 is to make them feel better. And if we can't do either of those things, then we shouldn't do anything. Because again, we do not want to make the cure worse than the disease. So treatment goals with atrial fibrillation are to prevent stroke. That's number 1. If I'm going to see you as a patient for atrial fibrillation, that's going to be my number 1 thing is, if I find out that someone has atrial fibrillation, I'm looking through their stroke risk, we're having a discussion about that. Secondly, I'm going to look at how well the heart rate is controlled because I want to avoid that tachycardia-mediated cardiomyopathy. Again, that takes some time to develop. So it's not just you have a couple days of a faster heart rate and suddenly you're in heart failure. That's not how that works. But again, controlling heart rate and then restoring and maintaining normal rhythm when appropriate. In some patients, it's not appropriate, like my uncle, for example, who's been in atrial fibrillation for 20 years. The chances of us helping him maintain normal rhythm are very low because of multiple factors. So stroke prevention, how do we do this? How do we figure out what patient needs to be on a blood thinner and who doesn't? Well, we use something called the CHADS-2 VASC score. Each letter of CHADS VASC stands for something, and we count up this number, and then we use the evidence to guide us on what would be the safest for each individual patient. So the C in CHADS VASC stands for congestive heart failure. This means, has a patient ever had a history of heart failure or impaired left ventricular ejection fraction or heart pump function, which a normal EF or ejection fraction is 55% or higher. So if it's lower than that, that would be an impaired LVEF. This is chronic or acute heart failure, and it's if the patient has ever been treated, not just if they're actively in heart failure now. They get 1 point. The H stands for hypertension. The patient has ever been treated for high blood pressure, whether it's well controlled or not, they get 1 point. Age 2, they get 2 points if they are 75 or older. Then the D is for diabetes. They get 1 point if they have ever had or been treated for diabetes. S2 stands for prior stroke, mini stroke or transient ischemic attack, or a thromboembolism, which how I like to ask patients is, have you ever had a stroke, mini stroke, or blood clot anywhere in your body? There used to be this thought that if there was a provoked like DVT, the patient had trauma or surgery, that we didn't count it. But a lot of the evidence shows that provoked suggests a predisposition for thromboembolic complications. And I am a super conservative provider when it comes to preventing stroke, and I want to err on the side of caution. I can fix bleeding better than I can fix a stroke. So if a patient has ever had a blood clot, I give them 2 points. The V stands for vascular disease. Now this would be an actual diagnosis of obstructive coronary artery disease, like myocardial infarction and some kind of intervention, peripheral artery disease, or aortic plaque. And for peripheral artery disease, there needs to be a clinical diagnosis through claudication, critical limb and acute limb ischemia with diagnostic evidence like the ankle brachial index being less than or equal to 0.9. This is just an index that compares blood pressure in the ankle with the arm to assess arterial blood flow, or ultrasound CT, MRI angiography showing narrowing or blockages. If the patient has ever had peripheral artery stenting, angioplasty, bypass surgery, or amputation. What does not qualify here are just suspicion, but no diagnostic criteria. Generally doesn't count. Venous issues and pain or neuropathy. Then the next A stands for age 65 to 74. They get 1 point. And then the last S is for sex. Female, you get 1 point if you're a female, but only if other risk factors are present. Being female alone does not increase your stroke risk, but it does interact with other risk factors to enhance the risk for stroke. So how do we prevent stroke? The best evidence says that in patients who have a stroke risk score of 2 or higher in men and 3 or higher in women, if you were paying attention and following along, the stroke risk score can go all the way up to 9. 2 and 3 are really the most important numbers. If they have a 2 in men, 3 in women, the evidence suggests that the risk for stroke is higher than the risk for bleeding on an anticoagulant. Therefore, I would start an anticoagulant in anyone that came to me with that stroke risk, so long as they didn't have some outstanding bleeding issue, which is why it's very important for this to be managed by a cardiologist or electrophysiologist, because we will go through these things every visit. What kind of anticoagulation do we use? Back in the day, we used to use warfarin or Coumadin, and this blood thinner would inhibit the synthesis of vitamin K-dependent clotting factors. But while it is very cheap, it is difficult because it requires very close monitoring, and changes in diet can make the levels fluctuate. So it was amazing when they came out with the direct oral anticoagulants, also known as DOACs. The DOACs include apixaban, Eliquis, rivaroxaban, Xarelto, edoxaban, Savaysa. These are all factor XA inhibitors. Factor XA is the key enzyme that converts prothrombin into thrombin, which converts fibrinogen into fibrin, which forms the structural basis of a clot. And by inhibiting factor XA, we prevent the generation of thrombin, reducing the formation of fibrin clots. The reversal agent for this is adenosine alpha, or Andexxa, and that is what apixaban, Eliquis, rivaroxaban, Xarelto, and edoxaban, Savaysa is. I don't know how to say that very well, edoxaban, because I don't use it very often. And the reason that we don't use it very often is that in the Engage AF TIMI 48 trial, it showed reduced efficacy in patients with high renal function. So it's actually not recommended in patients with a creatinine clearance of greater than 95. So that means that its use is limited in younger, healthier patients. As I was doing the research for this, I was like, oh, well, I see edoxaban here and there, but I don't prescribe it typically. And I don't know anyone that really does. And I was like, why is that? And then I found that out. So that's a little clinical pearl for you. And then there is dabigatran, or Pradaxa, which is a direct thrombin inhibitor, which factor 2A converts fibrinogen into fibrin. Pradaxa has a reversal agent also called Praxbind. Important education around these anticoagulants would be for Pradaxa, this medication needs to stay in its original packaging until right before it's being administered. Once the tablet is exposed to the air, it begins to break down. So if you put Pradaxa in a pill box for a week, it may lose its efficacy. So you want to keep it in its original blister pack or in the pill bottle with the desiccant. So I have to make sure that I educate my patients on that all the time. Many times you'll find that patients were never told this, or they missed the warning, or they didn't notice it from the pharmacy. So I make sure every patient that I have that is on Pradaxa, I reiterate this teaching at every touch point just to make sure. And I'm sure the ones that have paid attention and I see regularly roll their eyes at me when I say it, but it's very important to me that none of my patients have stroke. And actually, that's one of my biggest goals in patients with atrial fibrillation is that no one is having strokes. With Xarelto, it is typically most therapeutic when taken with a high-calorie meal, so we usually have patients take that with their largest meal of the day. Eliquis just needs to be taken twice a day. If for some reason a patient cannot be anticoagulated, there are other options with left atrial appendage ligation or left atrial appendage occlusion. That is kind of outside of the scope of this podcast, and I will have an episode on that option in the future, and I do have a couple reels on social media talking about it if you would like more information. So what if you don't meet the criteria for anticoagulation? What if you don't have a stroke risk score of 2 or 3? Then you don't need to be on anticoagulation unless you are undergoing a procedure. In the perioperative period, the time before and after, either having an ablation or a cardioversion, which we're about to talk about, we do want patients to be on anticoagulation to protect them from stroke because they are at higher risk. So how do we treat atrial fibrillation? Well, we have rate control and we have rhythm control. Let's talk about rate control first. The goal for rate control is to keep the heart rate well controlled, even if atrial fibrillation persists. That is the goal for my uncle. Our goal is to keep him having a normal heart rate profile so he does not develop tachycardia-mediated cardiomyopathy. How do we do this? Well, we do it with medication. 2 different medications that we typically use, beta blockers and calcium channel blockers. We can also use an older medication called digoxin. But let's talk about beta blockers first. If you think of your heart like a car, beta blockers push lightly on the brake pedal so that the engine doesn't run too fast. The main type that we use mostly works on the heart itself, but some beta blockers also affect the lungs, which is why if someone has asthma or COPD, we usually choose the heart selective kind. Beta 1 receptors are cardioselective on the myocardium and the conduction system, and beta 2 receptors work on vascular and bronchial smooth muscles. So beta blockers can prevent the effects of catecholamines like adrenaline and norepinephrine released by the central nervous system. They reduce the firing rate of the sinoatrial node. They have a negative chronotropic effect. They slow the AV nodal conduction, prolonging the refractory period, which means that nothing electrically can happen during that time. They also reduce the oxygen demand, beneficial in atrial fibrillation patients with ischemic heart disease, again, suppressing sympathetic overactivation. So the selective beta-1 blockers that are preferred in patients with lung disease are like metoprolol, atenolol, and bisoprolol. Non-selective are propranolol and carvedilol. Carvedilol has alpha blocking, so it's also good for patients with high blood pressure and congestive heart failure. Calcium channel blockers like diltiazem and verapamil are the non-dihydropyridine. These selectively block L-type calcium channels in cardiac muscle cells. This reduces the electrical activity in the heart. They're contraindicated in patients with heart failure with reduced ejection fraction due to this stronger inotropic effect, but can be preferred in those with angina, secondary to stronger vasodilatory effects. Calcium channel blockers reduce the strength of muscle contraction, helping decrease the workload of the heart and the oxygen demand. So it's a reduction in myocardial contractility, which is the negative inotropic effect. It also relaxes smooth muscles in the blood vessel, improving cardiac function in patients with high blood pressure and atrial fibrillation. It can be useful in patients who don't tolerate beta blockers. And the last thing that we can use for rate control is digoxin. This is less common and older, and definitely second line. It's derived from the leaves of the foxglove flower. It increases vagal tone and suppresses conduction through the AV node, prolonging that refractory period. It has a slow onset of action. It's better for patients that are more sedentary. It doesn't work as well during stress and exercise, and it definitely has a narrow therapeutic index. It can cause toxicity, nausea, vomiting, anorexia, visual disturbances. Patients can report yellow halos and arrhythmias. All of these risks are higher with renal impairment because it is excreted by the kidneys. It interacts with other medications like amiodarone and calcium channel blockers also. I remember in nursing school, we learned right away that we could not administer it unless we took an auscultated pulse, which means we had to place our stethoscope on the patient's chest and listen to it for an entire 60 seconds. And it had to be greater than 60 beats per minute before we could administer digoxin. And that happened many times when I was a bedside nurse when I had patients on that medication. So, the limitations of these medications with beta blockers, well, actually with all of them, it can cause bradycardia, which is a heart rate less than 60 beats per minute. It can increase heart block, which isn't like artery block, it's conduction block. They can cause low blood pressure. With the beta blockers, you can have exacerbation of asthma and COPD. Calcium channel blockers need to be avoided with heart failure with reduced ejection fraction. They are also metabolized by the cytochrome P453A4 enzyme, and this may interact with other medications. So we've talked about rate control and the different medications we can use for that. Now let's talk about restoring rhythm. Let's get back to normal rhythm. How do we do this? Well, we can do it with medication, or we can do it with cardioversion. Cardioversion can be with medication, or it can be electrically with a shock, or we can do a catheter ablation. Let's start with the medications. Medications are typically classified by something called the Vaughan-Williams classification system. I'm just going to briefly touch on it because it's definitely outside of the scope, again, of this podcast. I'm trying to keep it a little bit more simple than not, but as we all know, electrophysiology can get really deep. If a patient does not have a history of structural heart disease, coronary artery disease, or heart failure with reduced ejection fraction, we typically turn to the class 1C antiarrhythmics, flecainide or propafenone. These medications block fast sodium channels, they slow conduction, and suppress ectopic activity. They're usually well tolerated and don't have many reported side effects, at least in my experience. Because they can be ventricular proarrhythmic in patients with structural heart disease, typically get a routine stress test and echocardiogram every 2 years. With flecainide and propafenone, they are typically given with a calcium channel blocker or a beta blocker to avoid very fast ventricular rates. So if flecainide or propafenone don't work for a patient, or if they have structural heart disease or another contraindication for flecainide or propafenone, then we can consider sotalol or dofetilide. These medications are typically started in the hospital because they have the potential for QT interval prolongation. And with that, that increases the risk for ventricular arrhythmia that can cause sudden cardiac death, called torsade de pointe. And that is seen within the first 5 doses. So when we start this medication, we typically have patients come into the hospital, get an EKG after every dose, and they're also monitored on telemetry. It isn't very common that this would happen, but if it does, we can monitor it, and if needed, we can decrease the dose of the medication or decide not to use that medication at all. Sotalol and dofetilide are a class 3 antiarrhythmic, and they block potassium channels that prolong the action potential duration and refractory period. And if flecainide, propafenone, sotalol, and dofetilide don't work or the patient can't tolerate it, we come to amiodarone. Amiodarone is typically considered a class 3 antiarrhythmic, but it also has characteristics of 1, 2, and 4, so it's sometimes considered a broad spectrum antiarrhythmic. Amiodarone is very effective in managing atrial fibrillation. However, it does come with some risks. There is another medication that is closely related to it called dronedarone or Multac, and we can also use that in many patients, but they can't have active heart failure symptoms. It does not have the iodine component that amiodarone has, so it has less toxicity, which is one reason why I don't love to use amiodarone long-term in my patients who are younger, because it has the potential for toxicity over time. Amiodarone has a very long half-life, approximately 58 days, and does take some loading time for it to be therapeutic. Risks for toxicity to 5 different body systems: the lungs, eyes, liver, thyroid, and skin. We have to monitor the patient for hypo and hyperthyroid, hepatotoxicity. We do this with thyroid function and liver function tests every 6 months. Interstitial pneumonitis or pulmonary fibrosis. Typically on initiation, we order pulmonary function testing, and then we get a chest x-ray yearly. Corneal deposits and optic neuropathy. So we have the patient see an ophthalmologist or an optometrist once a year. That's our routine amiodarone surveillance. Some other side effects that patients report are neurologic, with like tremors, ataxia, or peripheral neuropathy. And some patients do have photosensitivity, and in some cases, patients' skin has turned gray or blue, which is very interesting in textbooks. I haven't seen it in real life though. So now that we know about the different medications that can help with rhythm control, what if you're in atrial fibrillation and you need to get back into normal rhythm? Well, we can use these medications. Sometimes they will help patients convert chemically. Flecainide and propafenone are about 70 to 90% effective, and a lot of times we can use flecainide and propafenone as a pill-in-pocket medication. Like a patient has paroxysmal atrial fibrillation, and when they have an episode of atrial fibrillation, they take a beta blocker or a calcium channel blocker, and then they take the flecainide or propafenone and sometimes convert back to normal rhythm. And this worked really well. Dofetilide can also convert patients back to normal rhythm. Dofetilide is 50 to 60% effective in converting patients back to normal rhythm, and amiodarone is 60 to 80% effective. So what happens if we can't chemically convert a patient? Then they have to come in for a direct current cardioversion. And that's where they get a little bit of anesthesia and they get shocked back to normal rhythm. If a patient hasn't been anticoagulated prior, for at least 3 weeks, we do a transesophageal echocardiogram to make sure that there is no clot in the heart prior to converting them to normal rhythm. Another way that we can achieve rhythm control is with a catheter ablation. Catheter ablation was pioneered by Dr. Melvin Scheinman. Please see episode 2 for more information about him. When he performed the first ever in a human in 1981 at UCSF Health. It is a minimally invasive procedure where an electrophysiologist will access the heart through big veins where the leg meets the torso, which is what we call the groin. They will place basically a large IV there and thread catheters up into the heart. They do a full electrophysiology study. While the patient is being prepped, they place pads on the front of the patient and on the back of the patient, and then they're able to map the voltages in the heart and do a full electrophysiology study to see where the signals are coming from and where these arrhythmias are originating, which is how they find out what they want to ablate. Typically, for atrial fibrillation, they do what is called a pulmonary vein isolation. Pulmonary veins are usually the trigger sites for atrial fibrillation, and it's really kind of a cool thing if you think about it. I'll link a study from the 90s that linked pulmonary vein ectopy to atrial fibrillation initiation. Pulmonary veins are trigger sites because it's where pulmonary and myocardial tissue meet, kind of like where, like in the San Francisco Bay, where fresh water and salt water make brackish water. So it's just this place where there's autonomic innervation, junctional heterogeneity, and it just makes it ripe for this electrical malfunction. So there are different types of ablation. So typically we want to isolate these pulmonary veins, which will then help atrial fibrillation not be induced. So the types of ablation are cryoablation, which is freezing. It's balloon-based, safer for critical areas like the AV node, coronary arteries, and the phrenic nerve, as it allows for reversible lesions. It's less effective in persistent atrial fibrillation and ventricular tachycardias. It's not something that we typically do all the time, and that's more of an electrophysiologist operator level decision on what's going on with this. Kind of what used to be the standard was radio frequency ablation, and that's with thermal heat. It's very precise, it's point to point and widely available. And we are now using something called pulsed field ablation, which is electroporation, and it only targets myocardial cells, which are the heart cells. We were involved in some of the clinical trials, and now we are using it since it's been FDA approved. There is less collateral damage because it targets only myocardial cells. The ablations take less time, and there's less risk to the esophagus and to the phrenic nerve. Risks of ablation, like big ones like heart attack, death, stroke, less than 1%. We don't typically see any of those, because this is an elective procedure, which means it's not emergency. We're not taking sick people back to have ablations. And anytime we go into the heart, there's risk for bleeding around the heart and lungs. We can cause inflammation, cause pericarditis. Some patients will have some chest discomfort that worsens when they take a big, deep breath, and that's just from the inflammation caused by the procedure. I'd say that the biggest effect that we see from an ablation is bruising at the groin site. Typically looks like somebody punched patients pretty hard in the groin, and the bruises are beautiful because everyone is on a blood thinner. And then they change color and they run down the leg due to gravity. And some patients were like, I wish I would have been told that. So I make sure that whenever I'm doing any teaching about ablation, that I remind patients that they could have big, beautiful bruises because of the blood thinning agents that are used. There are smaller complications like pulmonary vein stenosis, phrenic nerve injury, esophageal injury, esophageal atrial fistula, which is very rare and life-threatening. Some patients can also have some nerve damage at the groin site. But after I did a deep dive into the literature, I found that every case that's ever been reported has resolved within 90 days. And even with patients that I've had that have experienced it, which has been rare, like 1 or 2, it has completely resolved. Atrial fibrillation is not considered curable even with catheter ablation. We can manage atrial fibrillation very well with an ablation. Some patients will need more than one ablation. The reason that we would pursue rhythm control is because it does lower the risk for stroke, heart failure, reduces hospitalization, and reduces that risk for dementia. So once we have it treated and we know what we're dealing with it, what can we do outside of rate and rhythm control? Well, we definitely need to pay attention to our risk factor modification. So what are the modifiable risk factors? Well, let's start with what are the non-modifiable risk factors. I can't help you with anything regarding age or genetics. We can't modify those. That's just what they are. But we can modify a lot of things, like having well-controlled blood pressure, having well-managed diabetes, maintaining a healthy weight or decreasing obesity, tobacco cessation, the identification and treatment of sleep apnea. Patients with sleep apnea have a 2 to 4 increased risk of AFib. It increases the recurrence of atrial fibrillation after cardioversion, ablation, and antiarrhythmic drugs. So When you stop breathing at night, this causes hypoxia, which leads to oxidative stress and inflammation, increases the atrial stress and pressure, which promotes structural and electrical remodeling in the atrium, which increases the susceptibility to atrial fibrillation. This also activates the sympathetic nervous system and is closely correlated with high blood pressure and obesity. And all of this is strongly associated with AFib recurrence. CPAP treatment can reduce risk if you do have it. So I screen my patients for sleep apnea, and I have no problem referring them to our fantastic sleep medicine team at UCSF for evaluation and treatment. There was a fantastic article in the September 2023 edition of Heart Rhythm by Mills, Antman, and Java Harry called Breathless Nights and Heart Flutters, Understanding the Relationship Between Obstructive Sleep Apnea and Atrial Fibrillation. And I highly recommend that read for anyone who may have sleep apnea and any healthcare provider, nurse, anyone that has patients that may have atrial fibrillation or have sleep apnea. It's a great read. So what other modifiable risk factors are there? Let's talk about caffeine and coffee. UCSF has done large-scale studies and meta-analysis on this. Moderate intake of coffee does not increase AFib risk and may have a slightly protective effect due to its ability to reduce systemic inflammation and improve endothelial function, but there is individual variation. While coffee may have a slightly protective effect, energy drinks have potential risk because they have high doses of caffeine coupled with other stimulants like taurine. This can increase the risk of arrhythmia in susceptible individuals because of excessive sympathetic stimulation. What about alcohol? Even moderate amounts of alcohol worsen AFib, and in the studies done at UCSF, we've found that just one alcoholic drink can trigger atrial fibrillation. However, more association with binge drinking. Abstinence improves outcomes. Chronic alcohol consumption is associated with increased atrial size and remodeling, fibrosis of the atrial tissue, and conduction abnormalities. What about marijuana? UCF studies are ongoing on this, but it does show that it has some possible proarrhythmic effects. It can cause tachycardia, high blood pressure. It increases sympathetic activity. So the best recommendation is to avoid heavy, frequent use. In summary, the modifiable lifestyle considerations are to maintain a healthy blood pressure, manage and screen for diabetes, maintain a healthy weight or reduce obesity, stop smoking, identify and treat sleep apnea, avoid heavy and frequent marijuana use, avoid or decrease alcohol use, and definitely don't binge drink, maintain a heart-healthy diet, stay active and exercise, get good stress management, good sleep habits, and avoid stimulant use. So we've talked about the heart's normal conduction system. We've talked about what atrial fibrillation is. We've talked about the risks of atrial fibrillation. We've talked about rate control and rhythm control. And we've talked about modifiable risk factors. What's next? Well, patients that have atrial fibrillation, we don't ever consider cured. We just manage atrial fibrillation well. We definitely want patients to have long-term monitoring with a wearable like an Apple Watch, a Garmin, a Fitbit, or even something you can spot check your rhythm with like a Cardia device. I don't recommend relying on blood pressure cuffs or pulse oximeters to give you your pulse because with extra beats and things like that, sometimes doesn't even give your pulse rate right and it doesn't tell irregularities well at all. You may undergo routine 2-week monitors with your healthcare providers occasionally. Some patients do have implantable loop recorders. You should also monitor your heart rate, and especially in patients who don't have symptoms and they don't know if they're in atrial fibrillation, or if your heart rate's at 120 for weeks and weeks and weeks, you're at risk again for that tachycardia-mediated cardiomyopathy. So it's really important to have regular follow-up with a cardiologist or an electrophysiologist. It's really important to be informed and to participate in shared decision-making. I went over all of these different things that play into atrial fibrillation, and there are so many different ways that it can be treated. I like to tell my patients that there's not a right or a wrong answer. There's only a right answer for you because this is your health and your heart. So atrial fibrillation is common. It's the most common dysrhythmia of the heart, but it's manageable and we can manage it very well. Stroke prevention is the first priority. And then we decide on rate control versus rhythm control. Both are important, but rhythm control offers broader benefits. Ablation works by isolating or fencing off the pulmonary vein sparks, if you will. Lifestyle and risk factor modification are definitely powerful tools that can help prevent recurrence and manage that rhythm very well. And with the right care plan tailored to each patient, patients can live well with atrial fibrillation. The reason I wanted to have this episode on just basic information of AFib and AFib management was so that my patients could re-listen after visits for reinforcement. Imagine getting all of that in less than 30 minutes in a visit with me when you're first diagnosed with atrial fibrillation. It's like drinking from a fire hose. That was one of the main reasons that I wanted to share this episode, because I want my patients to be able to have a place to come back to listen to what atrial fibrillation is, how we treat it, what's important to remember about it, so that they can make good decisions for themselves. And I wanted other healthcare providers and nurses and the general population just to know more about atrial fibrillation. So I appreciate everyone listening to this episode. Thank you for supporting me and supporting making healthcare and little bits of electrophysiology more accessible to everyone. I'm looking forward to sharing more about the heart rhythms, and healthcare in general with all of you. Thank you so much. Thanks for tuning in to this episode of In the Loop with Nadja Wlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.